In addition, if somebody is able to find a dentist and a dental provider, making sure that they participate with their insurance is another challenge and sort of another layer to this challenge. So if an individual in a rural area is able to find a dental provider, finding one that actually accepts their insurance tends to be more challenging. We know that the demand for dentists in a lot of cases outweighs the current supply, and so dentists are able to charge cash and not participate with any insurance and sort of bypass that administrative burden. But then again, it does prohibit individuals from seeking or receiving care if they are dependent on their insurance as a payer. In 2017, there were large contiguous rural areas across the northern part of Pennsylvania, as well as in the central region of the state, where there were actually no dental providers accepting Medicaid. Access to specialty providers is challenging as well. So when we're looking for a dentist in general, sometimes we can find a general practitioner, but if we look for something like a pediatric dentist or an oral surgeon, again, that's another added layer of challenges. 90% of general dentists will treat patients 5 and up, but only about 12% will treat infants and young children. And so if we need to find somebody to treat a child and to treat their early childhood decay, it becomes challenging to find a general dentist who will do so. When we start looking for a pediatric dentist who will treat those young children, every urban county in Pennsylvania actually has a pediatric dentist, but only about 23% of Pennsylvania's rural counties have pediatric dentists located within them. So again, a lot of times families are having to travel to access that care. When we get into travel and the barriers around that, not only do residents have to have a reliable source of transportation, and again, good weather, but oftentimes if they're driving 2 hours one way, they're having to take time off of school and work, and that adds challenges also. We know with COVID, there has been a decrease in dental providers. So back in 2015, 1 in 4 dentists had reported a plan to retire within about 6 years. And those retirement plans did end up coinciding with COVID. And so when dental offices were forced to close down during the early stages of the pandemic, a lot of offices chose not to reopen. There were a lot of financial burdens with reopening, so making sure that they had all of that infection control in place to be able to safely reopen post-COVID, and there were offices that chose not to do so. So again, we don't know exactly how many, but we know that there were offices that just chose to go right into retirement. They were planning to go down that path anyhow, and COVID may have expedited those retirements. All right, so we'll go to the next slide, Helen. Thank you. So out of Pennsylvania's approximately 12 million residents, 3.4 million are living in rural areas. It actually ends up being about 25% of Pennsylvania residents living in rural areas across the state. When we look at patient to population, or really in this case, it's more dentist to population ratios, there were about 55 dentists to 100,000 residents located in Pennsylvania's urban counties, and only about 36 dentists per 100,000 residents in urban counties, or I'm sorry, in rural counties. When we look a little bit further at those rural counties, there were actually 4 rural counties, and this is 2015 data, but there were 4 rural counties that only had a 20 to 100,000 ratio, so even less than what a lot of the standard or the average of the rural counties had. And then we'll go on to the next slide. So we have a dental safety net. We do have options available, facilities available for those that are seeking dental care, and that may help with some of the insurance options as well. A federally qualified health center is one of those options where patients may choose to seek dental care. And we do have quite a few. We have about 264 sites in Pennsylvania. And again, this was 2018 data. So 264 FQHC sites. And there were 44 out of Pennsylvania's 67 counties that had FQHCs located within them. FQHCs provided care, this is medical care, but they provided care to over 775,000 Pennsylvania residents. And FQHCs actually must have an option in place to connect patients to dental care. About 90% of FQHCs provide dental services on site. For those 10% that are not providing services on site co-located with their medical services, they do have to have an agreement in place to be able to help their patients access dental care. There are FQHCs in about half of Pennsylvania's rural counties. There are 48 rural counties in Pennsylvania currently, so a good portion of this state. And again, a lot of them do have dental clinics on site. So medical is able to refer over to dental, and dental is able to refer to medical. In 2018, there were 121 full-time equivalent dentists practicing in FQHCs, and there were 84 full-time equivalent dental hygienists practicing in the FQHC setting. Another option with the dental safety net is sort of the world that I work within, and that's the rural health clinic world. And so medical dental integration, when I came to the office back in 2016, was my pilot program that we were working on. And so we worked with what was the DentaQuest Institute at the time. They are now the CareQuest Institute, but they are still the same group of people, same company, same mission, and they were working on MoreCare, which is medical oral expanded care. And the idea was integration of oral health into the primary care setting, and then coordinating that care with community resources. And so we did a year-long learning collaborative. We started with 9 rural health clinics in the state, and we worked with actually the whole office. So not just the medical providers, but the nursing staff, the front office staff, and we did a deep dive into oral health and how primary care can help and why oral health should be included in the primary care setting. So with that pilot program, we actually did 2 years. And there are still currently, to this day, 13 rural health clinics that are integrating oral health into their primary care practice, meaning their medical providers will do things like oral health risk assessments. They'll have discussions about oral health self-management goals. They'll apply fluoride varnish, and they'll refer to a dental provider if the patient needs that referral. And so that is happening at all pediatric well child visits, and a lot of these clinics have actually started to make it part of what they do for their adult visits as well, because they found the value in this integration. We do currently have about 7 rural health clinics in the state, and we have about 70 in total, and about 7 of them are offering some form of dental service on site. And as you know, we don't have to have dental services in an RHC setting. And there actually doesn't even have to be a connection to dental services like that FQHC rule. But again, these RHCs have found such a value in dental and such a need in their community that they have started to integrate those dental services on site. So I'll let Helen talk a little bit about free clinics.
Yeah, thank you. So with our free clinics, and I know that not all states have free clinics, but when we refer to free and charitable clinics, we're talking about volunteer-based safety net healthcare organizations that provide quite a range of medical, dental, pharmacy, behavioral health services, typically at no cost to low-income families who are usually uninsured or underinsured. So these free clinics generally operate as nonprofits, and though they usually have a skeleton staff for administration, they may have 1 or 2 paid employees. They typically rely on many volunteers to actually provide health services. Some are brick and mortar clinics that operate year round. Sometimes even pop-up events like remote area medical events or Mission of Mercy events can be considered a free and charitable clinic. In Pennsylvania, up until about a year ago, we were actually looking at 63 free and charitable clinics in the state. These facilities were hit exceptionally hard from the pandemic because, one, they're already sort of on a shoestring budget, but they're also relying on healthcare providers who have time to volunteer and who are willing to give up their time free of charge. With the shutdown that happened in dentistry and across a lot of health fields, and with the increase in need of services, really we're just not seeing the healthcare providers wanting to volunteer anymore. And so, of course, it's hit our free and charitable clinics pretty hard. As you can see on the slide, a decrease from 63 sites to 37 right now. So that's a really big cut in the services that are offered out there. 8 of those current clinics are located in rural counties in our state. And, some of them offer dental, some do not. So at best count, 17 of the 37 right now are offering dental services. And I will say, it ranges where they may have someone come in 1 day a month to having, full-time, 40 hours a week of dental care being offered. One of our free clinics actually only offers dental care. So, it's a pretty big variety, but it does help to serve that population that may not have access to healthcare providers in other areas. The last kind of piece of our safety net for dental in Pennsylvania would be our school oral health programs. And to not delve into so much detail, our school programs are quite involved, but we are one of very few states that have a mandated dental screening that's required by law. So the state actually asks all schools to collect dental screenings at 3 distinct ages. So they grab the kids when they come into school, either kindergarten or first grade, and then again, they catch them in grades 3 and grade 7 to do a mandated screening. The information on the student's dental health is collected, but not really compiled into any kind of real database. So unfortunately, those data can't be used for research or surveillance. Schools get a very modest health reimbursement for getting those screenings done. Depending on the type of program they run, they get anywhere from 80 cents to $2 per child. But there's really no stick for noncompliance. So when we talk carrot and stick, is $1 a child really a carrot? Probably not. And when there's no stick, what we see is that schools aren't always compliant in getting those screenings done. Pennsylvania is also even more unique in that each of our 500 school districts is able to select whether they want to offer one of 2 types of dental programs. The first is a mandated dental program where they actually have a dentist from the community who comes in once a year, completes the mandated screenings. The majority of our districts in the state, 470 of the 500, actually opt for that. The remaining 30 offer what's called a dental hygiene services program, and that's when the school district actually hires a dental hygienist as a staff person, as an employee of the school district. So, we joke and say they get the teacher hours and they get to have the summers off and no evenings and weekends, but they're actually working as a dental hygienist within the schools. That's been a program that has been declining over the last 10 or 15 years as school budgets lose funds. So at this point, we just have those 30 districts in the state that have that dental hygiene services program. Some of those programs offer clinical services and some just do the mandated screenings and do education in the classroom. The other piece that we talk about when we look at school oral health programs is we talk about school-based health centers. And probably those of you from states other than Pennsylvania know a lot more about school-based health centers and have a lot more school-based health centers. Our state, for being the 5th most populous state and being a very high population state, has very few school-based health centers. And that's something that we're trying to grow. Right now, we're looking at, there's a little over 30 schools that have these school-based health centers, and not all of them offer dental services. So it's a great way. We're trying to figure out ways that we can get more of those facilities on site because it meets the kids where they're at in the community. And can really serve the entire community and not just the school-age kids. So when we look at dental providers, so we talked about the safety net, where people are seeking care and where they're getting care, hopefully. We also have to look at sort of the numbers around dental providers. It isn't really just a numbers game, obviously. We know in many areas of the country that, healthcare providers are not always willing to accept medical assistance or Medicaid as they are other insurances. Kelly mentioned the problems we run into in dental and how really at this point dentists don't even have to take private insurance and they're still able to make a good living. So in Pennsylvania, we ask all dentists when they renew their license biennially to answer a survey. It's pretty much mandated. You have to work really hard to get out of it. So we have a great response rate, which many states are not as fortunate to have. So we get about over 90% of our dentists that actually answer the survey when they renew their licenses. Really, really rich data. So when we asked in 2019 how many take medical assistance, we found out that only 23% of general dentists actually said yes. And that number's been pretty stagnant for the last 7 to 10 years. It's that 1 in 4 are accepting medical assistance. So in 2019, there was another question added that kind of rephrased it a little bit and said, do you see any and all Medicaid patients? So are you seeing, are you participating with all the different managed care organizations? Do you accept new patients that have Medicaid? Do you see young kids? And our yeses actually dropped to about 7.9%. So less than 8% of our dental providers in the state are actually accessible to people who are enrolled in Medicaid. And for our state, that's over 3 million people, which is pretty significant. So you can see the numbers on the chart here. What we really wanted to just do was a quick comparison. When we do workforce analysis from the coalition's perspective, it isn't just how many dentists are in a county. So as you can see, the example with Bradford here, there are 21 dentists that are licensed in Bradford County, and that's a county that's across the northern tier of Pennsylvania on the border of New York. When we kind of go down a little further and we say, are you registered with Medicaid? Do you actually have a Medicaid ID number? That number drops to 7. So we go from 21 to 7. Then when we say, okay, well, you accept Medicaid, but do you actually bill Medicaid for $10,000 of services every year? So we would call that a meaningful provider, someone who's seeing enough patients to make a difference. Then that number drops from 7 to 4. So we go from 21 dentists being available in the county down to just 4 who are actually actively accepting Medicaid patients. And we're starting to do some analysis on a county level. As you can see here, there's a couple examples, but we have to look at not just the total population and the total number of dentists that are available, but we also want to look at the number of people that are enrolled in Medicaid managed care and how they're being able to find a dental provider. So what we have found is when we start looking at insurance participation, we really cut that ratio of population to dentists in half. Like it's really, really significant. And so then, of course, you have to start to think, how do we build that workforce up in those areas? We are happy to say that in Pennsylvania, we had a House bill passed this spring called Boosting Oral Health in Rural Communities. And we're going to have a legislative arm of our General Assembly that does research is actually going to do an analysis of the oral health services available in rural communities. So we're looking forward to having that study out sometime in early 2022, and hopefully we can use that for some future advocacy. Kelly, I'll turn it back to you.
Sure, thank you. So when we look at workforce, we do look at the dental health professional shortage areas across the state. This is an example of 2019 data, and the darkest blue is going to be a whole county shortage designation. And so there are a couple of different ways that a designation can become. And so the full counties tend to be a low income designation for that county. So all 17 that are full county DHPSAs happen to be rural counties. That means about a third of our rural counties are full county designated. All of our rural counties do have some level of dental health professional shortage area designation. And so that could be a facility designation like an FQHC that gets designated. It could be a portion of the county that gets designated. I often look at, and I don't think you can't see my mouth on the screen, but one of the counties that's really close to our state capital in Harrisburg is actually Perry County. And Perry County sort of is close enough to Harrisburg that it doesn't get a full county designation, but it is still very rural, and there can be, depending on what side of the county you're on, still a considerable drive to get to Harrisburg. And so that's one example where a portion of the county is outside of that Harrisburg designation enough to be designated, but the full county doesn't get designated because of how close their proximity is to that more urban area. So again, we have full county designations in all of our, or in 17 of our rural counties. There are actually 4 urban counties, those light blue ones, that don't have any shortage designation at all. But unfortunately for our rural counties, they all have some form of shortage designation within them. So we'll go to the next slide.
Okay, thank you. So we are, as I mentioned, we're doing a number of data digs, trying to figure out some of our workforce issues. And we were fortunate to secure some funding to do a deeper dive using the American Dental Association's Health Policy Institute. So for anybody who's an oral health geek on the call, which there might be a handful of you, you've probably heard of the ADA's Health Policy Institute. They do a number of sort of economic infographics around dentistry. They have a wealth of information if you ever want to check out some really great stuff. And they really have a lot of stuff broken down per state. So if you're looking for things that are local to your state, they're really a great resource. So we've been working with the Health Policy Institute this year. And actually, they're doing a really nice workforce projection model report for us, as well as an inflow and outflow analysis. So looking at the reasons that we're losing dentists in the state, are they retiring? Are they moving out of state? You know, are they just quitting? And then what does the inflow look like? How many new grads are we getting? Are they staying in the state? Is anybody choosing to come to Pennsylvania to practice? So it's going to be quite an amazing report, and we actually just got the very first draft last night, so I haven't even opened it yet, but I know it's 113 pages of data deliciousness. So very, very excited to see where we're looking at for our state. But this was one of the preliminary outcomes they shared with us about a month ago, that they found out, you know, if you look on this chart here, we've already seen from 2015 to 2020, we've seen a decline in the number of dentists per person in the state, but we're not done. We're going to continue to see a decline through 2035. So that's a really long time. That we're going to continue seeing our number of dentists go down. The other drop we're seeing is, so this green line is just, hey, here's the straight number of dentists that are out there. But we see on this yellow and orange line that because so many dentists choose not to work full time, that we have a number of providers that even though they're a practicing dentist, they don't count the same. So if two dentists are only working 20 hours a week, they really only count as one dentist because they have to be available to see patients as well. So what we're seeing, especially in the dental workforce, and I think across a lot of healthcare fields, but dental was a little late to this party, is that we're seeing a much higher percentage of women entering the field who maybe aren't interested in practicing full time, or they take time off with families, or we're also seeing a trend where dentists were in private practice, they were owning their own businesses and they were setting their own hours. Now they're going and turning to more corporate models. So, you know, the places where they can go and just work for a company as an employee and they don't have to have all the HR headache and the small business headache. So we're seeing this trend where dentists who previously were working full time because they owned a small business and it was their livelihood, are now trending away from that and becoming more like a traditional employee. So if they want to take off Fridays or they only want to work 30 hours a week, it's much easier for them to do so. So we don't just track the straight number of providers in terms of the ratios here. We also look at that full-time equivalent. And as you can see, that number is also dwindling down quite a bit. So we lose almost 10 providers per 100,000 when we start to look at full-time equivalents. So very, very kind of scary trend that's happening.
So one way we can potentially recruit dentists to serve underserved areas and hopefully retain them in those underserved areas afterwards is through loan repayment. And Pennsylvania has a couple of different options of loan repayment for both dentists and dental hygienists. One of them is a state-based program, and that is the Pennsylvania Primary Care Loan Repayment Program. And this actually offers the opportunity for both dentists and dental hygienists to apply for dentists. It's up to $100,000 if they're full-time, serving full-time. And if they're part-time, it would be $50,000. And it's a 2-year term. Hygienists would be eligible for $60,000 for full-time service and then $30,000 for part-time service, again, also for 2 years of service in an eligible location or an eligible service area. There are also 2 federal-based programs. One, they're actually both through the National Health Service Corps, but one is loan repayment, and then one is actually a scholarship program. So looking at that loan repayment program first, you have to have an eligible site. And so those federally qualified health centers that we talked about a little bit earlier are automatically eligible sites. And part of the reason they're eligible automatically is that an FQHC must offer a sliding fee scale to its patients. And so that allows them to be eligible for this program. Rural health clinics are not automatically eligible, but they can choose to become a participating practice site in this program. And one of the requirements of participation is actually to offer that sliding fee scale. There is an application process that a site would need to go through in order to be able to have one of their providers employed at that site be eligible for this loan repayment program. This loan repayment program is for $50,000 for 2 years of full-time service, and then $25,000 for that part-time service. And again, this is a 2-year commitment for those providers, and this tends to be dental providers only. There's also a primary care side to it, but these are more physician-type providers. For current students, the National Health Service Corps program for scholarships actually helps to take care of the potential for loans on the front end. So rather than the student going into debt, this works as a scholarship would to pay for the schooling up front, so we don't get into as many loans and interest on those loans. And so the scholarship amount tends to be less, but again, there's benefit there because they're not accruing student loans through this program. Students do have to be U.S. residents. They do have to be committed to working in an area that is underserved, that is deemed eligible upon graduation. They have to obviously be enrolled in a dental school within the United States. And it's actually a 2-year commitment post-dental school that they are sort of signing up for to be eligible for this program. So it is it's a scholarship program, but there is sort of a commitment to it that as that student graduates from dental school, they will go on to serve in an eligible location for 2 years to be able to have received that scholarship funding. And we'll go on to the next slide and then take a little bit of a deeper dive into Pennsylvania's program specifically. So this is the Primary Care Loan Repayment Program, and I actually had the opportunity to do a little bit of a deeper dive into this actually right before COVID. And so the state allocates funding for primary care loan repayment, both for primary care medical providers as well as dental providers and behavioral health providers. And so the state sort of allocates these funds, and out of that funding, they say, okay, 50% goes to our primary care medical providers, 25% goes to dental, and then the other 25% goes to behavioral health providers. They open this program up on an annual basis for application, and each application actually gets scored. So for 2019, there were 205 total applications to this program, and so that's from all providers, medical, dental, behavioral health, and there were 41 applications from dental professionals. And so this program is actually available not only to dentists, but to dental hygienists as well. The average percentage of dental, or the portion of the overall applications that were from dental providers, has been about 17%. And in 2019, with the 41 applications, 14 individuals were awarded some type of a dental loan repayment. So the average is actually 9, but they've actually seen an increase in dental hygienists applying to this program. And the amount that the dental hygienists are eligible for is less than the amount that dentists are eligible for. And so if more dental hygienists are awarded, there's a little bit more funding to go around and they can award more individuals. One of the ways, or there's multiple ways that these applications are actually scored, but some of the big highlights, there's preference given based on community needs. So where is this individual serving and what is the need of the community that they're currently serving? Did the individual who applied to the program graduate from a Pennsylvania educational institution? And so they look not only at, dental school or dental hygiene school, but also that undergraduate degree, if that's something that's applicable for the dentist. And they actually look at where were you before you went to college. So where did you go to high school? Did you grow up in Pennsylvania? Did you come to dental school from out of state? So those who grew up in Pennsylvania, did their undergrad in Pennsylvania, went to dental school in Pennsylvania, they will score higher than those who may have come in from out of state. Maybe they went to dental school out of state and they decided to move to Pennsylvania. They wouldn't rank as high within this program. So the idea is really, if we find a Pennsylvania resident, we find those individuals who are from the state, who either went to school in the state, they've never left, they're more likely to obviously stay, or if they left and they came back, but they're originally a Pennsylvania resident, again, they're more likely to stay. And so the emphasis here is really trying to not only help students out with their loans and sort of entice them to come to Pennsylvania, but once we get them here and they serve their 2 years, we really want to keep them here, and we'd really love them to continue to serve in those communities where they received that loan repayment. So hopefully, during this time where they're receiving the loan repayment, they're putting down roots in that community. Maybe they're buying a house, maybe they have kids that are starting school, and fingers crossed, they stick around for us, and so we have them available to continue to serve these communities even after this loan repayment is finished. So Helen, I'll turn it back to you.
Thank you. So now we're going to go a little further back in a pipeline. So we talk about our pipeline, meaning the capacity of the workforce to eventually become dental providers in Pennsylvania. So we have to look at dental students that are current dental students and even high school students to really come up with some permanent workforce solutions. So if you haven't done this already, or if this is something that interests you in your state, check out how many dental schools you have. That's a great first start. Pennsylvania has 3 full-time dental schools, which is a lot. Most states, if they have any, they may have 1, maybe 2. But you're able to actually go, the American Dental Education Association, which is commonly called ADEA, does have statistics available. So they get numbers from all the different dental schools. So you can actually go onto the ADEA website and check out your own state's applications and see where you're at. So, we're showing you the bulk amounts for our schools. So of those 3 full-time dental schools, almost 7,000 applications received. Now, that could be, of course, that one person applies to all 3 schools, because as is typical, some of these students will apply to upwards of 20 dental schools to ensure that they get in a spot. But when we look at those over 6,000 applications, we see that about 10% of them were from in-state. What's interesting is when we look at enrollment, we see a significantly higher percentage that are in-state enrollees. So of, those 3 schools, they're taking 350 students, but 125 of them are from Pennsylvania. And that is specific to each school. I will tell you that one of our schools in Pennsylvania has 12% in-state admissions. One has over 50%. So each school makes their own determination of how they're going to weigh the home state of their applicants. We're very fortunate that one of our schools is really proactive about that and understands that they need to allow in-state residents to get into their dental school. The other thing we do is when we start looking even further back and, we look at these students already in these dental programs, the dental schools, dental hygiene programs. We've been working on a project for the last 3 years, funded through our state's HRSA Oral Health Grant, where we're going in and we're talking to the students. We're having them read a book that's listed there, The Teeth Book by Mary Otto, which really explains the dental public health dilemmas in our country. And we've been able to have an in-depth conversation really with, let me think if I can get this right, it's about 750 students over the last 3 years that we've been able to meet face-to-face and talk a little bit about dental public health. So we want to make sure that these students are aware of life outside of private practice, that they can work and serve public health as a healthcare provider. The other piece we do is we look at our high school students. So when you're talking about getting providers in a rural area, we need to find students from those areas who then go on to be interested in dental programs, because we know that they're more likely to go back home. So what we want to do is we want to reach out to the high school areas in places of our state that are underserved. So we work with our area health education centers, and I'm sure many of you are already working with your AHECs. We've got 300 of them, I think, across the country. And then our HOSA chapter, which is the Health Occupation Students of America. Again, they have, I think, 54 charter orgs across the United States, and a little bit even outside of the United States. But the HOSA group, the Health Occupation Students of America, is really a student-led organization that does get some guidance from the U.S. Department of Education, and they are actively promoting career opportunities in the health industry to high school students. So we've been trying to work with them as well, so that if we can pull students who are already leaning towards health careers, maybe we can push that dental idea onto them. If they're a strong bio student, or even if they have some artistic skills, sometimes that's a really good fit for dentistry. So trying to identify those students that are the best possibility of going on to dental school and then coming back and serving their community. It's a long game. It's not something that we're going to fix our dental provider issues in the next 4 years even. This is going to be a 10-year plus problem. But we've got to start somewhere. So that's really what we've been looking at. So when we reach out to those high schools and we talk to these groups, and we've even reached out to Boy Scouts and Girl Scouts groups, we talk to them about what their options are in dental careers. So we've developed this document, we share, we give them a lot of information. We have a whole PowerPoint slideshow that we go through to talk about dental careers. And really, we're trying to find something that fits for everyone. So you don't have to be the valedictorian of your class. You don't have to be super sciencey. Maybe you're just more of a people person. There are dental careers that will fit that personality as well. So this is, just sort of what we do. We send this out to high schools, to guidance counselors, to career counselors. We also include a map of Pennsylvania DHPSAs, those dental health professional shortage areas, so they know that their area is in high demand. And then we give them a list of dental schools and dental hygiene programs in the state. So that way they can actually say, not only is this a great career choice, here are all my options of where I can go to school. So that's been something that we really have tried to focus on quite a bit.
So one of those career paths that is actually sort of unique to Pennsylvania in its name is the public health dental hygiene practitioner. And that's actually one of the newer career paths in Pennsylvania. This is a position or a role that was introduced back in 2010 as a direct access dental hygiene services provider. So essentially what this role allows is for a patient who maybe hasn't been to the dentist for several years to see a dental hygienist first. And so they can seek care from a public health dental hygiene practitioner. This is typically a registered dental hygienist who has at least 3,600 hours of documented practice under the direct supervision of a dentist. That comes out to be about 3 years of full-time practice working directly under a dentist. They can apply for this additional certification. And so really you have to have the documentation of those hours. You have to maintain your own liability insurance, and then there is some continuing education credits that are directly related to public health that need to be satisfied every 2 years with each renewal period. And these public health dental hygiene practitioners can work in public health spaces like FQHCs, like rural health clinics, and actually more recently, they can go into a physician's office, a general practitioner physician, as long as that physician's office is located in one of those DHPSAs. And they can provide dental hygiene services in those select locations. Nursing homes is another location where these providers can be utilized. They're able to bring those dental hygiene services to patients or residents in those areas, and then they make referrals out to dentists. And so they're able to do the cleaning. They could do preventative services like fluoride or dental sealants on teeth so that we can prevent decay. They can do all of that dental hygiene education, making sure that there's water being consumed at home, making sure that patients are brushing their teeth, those types of things. And so it's a preventive position. It does allow direct access. Dental hygiene services don't have to be prescribed by a dentist. They are able to do things like x-rays and then forward them on to a dental provider. And we have seen that there are hygienists or public health dental hygiene practitioners, longest acronym ever, PHDHP is what we typically say. But they are forming sort of relationships with dentists where they're able to sort of use this hub and spoke model. The idea is the dental hygienist is out in the field, goes to those patients, and then they're able to refer back to that brick and mortar clinic.
And right along those lines, we have the community health workers. Many states have models of community health workers. Same exact idea, but maybe just not actually offering the clinical dental services. So we have a lot of FQHCs and rural health clinics that are starting to be interested in using that community health worker, someone who's knowledgeable about the community they serve, and serves as a trusted resource. So for Pennsylvania, that position was first certified last year. So we've got about 50 or so on the registry for community health workers, and more coming by the day. So there's actually a process to certify them. And most of the programs that are training this curriculum for community health workers are including oral health in it. So we even have a course available on our website free of charge that anyone can take that's focused for community health workers. The other position listed here is the expanded function dental assistants. Many states have some version of these, but this is a dental assistant who has additional training to do some basic restorative services like placing fillings. So they're similar in, when we talk about a dentist extender, same as we talk about physician extenders. This is someone where the dentist can be responsible for treatment planning and diagnosing and can do the initial removal of tooth structure, but then the EFTA can come in and actually place the filling, which can really extend out the amount of time and the amount of patients that dentists can see. So they were first certified in Pennsylvania about 10 years ago, and we have about 2,600 of them certified right now in our state.
And then the other bright spot on this slide is teledentistry. And I think just like within the healthcare arena in general, telehealth, telemedicine, teledentistry, we've been exploring all of these options, especially over the past year with the shutdowns. Teledentistry and telehealth in general has sort of bubbled to the top of the surface. And I know there are still a ton of things that we have to look into to make sure that we're being compliant and we're billing and coding and all of the things. Essentially, teledentistry is not doing a filling through a phone. That doesn't work. But what we can do is actually, if a patient is in a location like a rural health clinic and there's a problem that's identified, and that dental specialist, maybe they're seeing a public health dental hygiene practitioner within that RHC. The public health dental hygiene practitioner can't actually diagnose cavities, but they have a pretty good idea when there's a problem happening. And so if they're able to connect with a specialist, like a pediatric dentist that may be 2 hours away, so that pediatric dentist is able to treatment plan before the family travels to see them to have that care taken care of, it does save a lot of time. So typically what we're seeing happening prior to teledentistry is the referrals made to a pediatric dentist, and that first visit, when the family makes that first trek 2 hours away to the pediatric dentist, they're only treatment planning. So they're identifying what needs to be done and how it's going to be done. Then they come back another time for that treatment to actually happen. And that gets very frustrating when you're traveling that distance. And so teledentistry can help to have that treatment planning done remotely, and that way when the family's making the trip to the dentist, the restorative services, those fillings and crowns, extractions, they can happen on that first trip, and there don't have to be multiple trips made. And so that's one of the ways that dentistry shows promise for the future.
So when we look at that, I just wanted to mention, and many of your states probably have state oral health plans. When we're looking at bright spots and ways that we can help, change things and really see some progress in our outcomes, it's really important that the state has a published oral health plan with some measurable outcomes and plans to actually move forward. So if you're interested, obviously you can check out our plan. It's pretty great, if I don't say so myself. I think it's an amazing 10-year plan, easy read, only about 25 pages, and really focusing on a lot of the stuff we talked about today: access, prevention, and education, workforce, and then infrastructure. So we have an advisory committee that's guiding that plan in Pennsylvania. We have lots of individual and organizations giving input, and we are tracking 22 specific measurable outcomes with goals. So just wanted to touch on that as just a piece of what's happening there. And then lastly, when we talk about future possibilities, some things that have sort of bubbled up, and again, not necessarily super fast things or things that could happen quickly. But, we know that we have a workforce in our foreign trained dentists. Many dentists are trained in other countries, but yet their education is not accepted for them to get licensed as a dentist in the States. So right now there are some options available. They can actually apply for a special advanced program, but they still have to go to dental school for 2 to 3 years, which is very tough and very competitive programs. We do have, I believe, one state in our country, Minnesota, that does allow provisional dental licenses to foreign-trained dentists without any formal education in the States, and that's worked really well. So, you know, I'm hopeful that we would see a better use, because we have these individuals that have been doing restorative dentistry in their home countries for years and years and years, and they come here and they can't practice dentistry. So, you know, we would love to see that, you know, used in more capacity. It would also, you know, bump up the number of services we can offer folks. Dental therapy is another piece that we talk about. This is more of what we would call a mid-level provider. So this is someone who typically has already worked in the dental field, gets some additional master's level training, and is able to do some basic restorative needs. So basic fillings, basic extractions, but they're actually meant to be working directly in the communities that they're serving. So we'd love to see, you know, more states. I think 13 right now have an active dental therapy model on their books. Pennsylvania has not ever looked into that really. So we'd like to see some of those models of care be used more in the, you know, coming 5 to 10 years, because again, that's going to help fit where we have those holes in our dentist providers.
And then true oral health integration, like Helen mentioned at the beginning of the presentation, really truly putting the mouth back into the body and really having medical providers think about the oral health like they do any other system of the body. So, you know, if we think about the heart, not everybody gets referred to the cardiologist. Just those that maybe need a little bit of extra TLC for their heart get referred to the cardiologist. And so could a primary care provider manage those healthy patients and refer them to the dentist as needed? So as they see problems come up, let's treat dentistry like any other specialty and manage the healthy patients on the medical side to help to sort of absorb those sort of need and the access issues on the dental side. One of the challenges there with all of the other medical specialties, typically EHRs are shared, especially within health systems, and information is able to be exchanged pretty easily from one provider to another. A lot of dental electronic health records don't communicate very well with the medical electronic health records, and dental providers tend to have some more needs. So we have things like dental charting and dental x-rays that we like to pull into our electronic health records. And so sometimes they don't talk very well, and so it's bridging those gaps in between the EHRs. We do actually have a system in Pennsylvania where they actually have just integrated a public health dental hygiene practitioner in their rural health clinic. Their rural health clinic is currently using Epic, and they just integrated Epic's version of Epic's dental software, so Epic's Wisdom, into that PHDHP's operatory. And so now she's able to have conversations with the medical providers that she works with. She's able to see health histories. The medical providers are able to see what, you know, happened on the dental side, where they might have been referred for further treatment, for further care. And so things are working well with that integration. They are able to talk to each other. With that also integration on the dental side, so sometimes the patient will see their dentist more regularly than they'll see their general practitioner. And so if the dentist or dental hygienist is taking a blood pressure, they may notice that there's a problem and then be able to refer back to that medical side as well. So really two-way referral, truly integrating oral health and putting the mouth really back into the body and thinking about oral health as part of primary care. So I know we went a little bit over, Helen. I'll have you go to the very last slide. But this is our contact information in case you'd like to continue the conversation after today's meeting. And I'll stop here. And if there's any questions, we're happy to entertain them.
Thanks so much, Kelly and Helen. I actually went over on time, so we still have a little bit of time for Q&A, which hopefully if you guys want to raise your hand, your virtual hand, or put a question into the chat box, you can go ahead and do that now. We still got about maybe 5 more minutes. While you have our presenters here, I would take advantage of it. So any questions, put them in the chat box or raise your hand or come off mute, and we'll sit back and wait here for a second. Edward.
This is for both Kelly and Helen. This is Ed. And for Kelly, the first question for your rural health centers, you said that they started integrating the health into the primary care oral health in 2016, and they now have 13 centers, and 7 are utilizing dental services within those clinics. Do you see those numbers increasing?
Hopefully. We did receive some funding. So one of the things that was actually in my notes to talk about, but I think Helen and I could sit here and talk all day, so we tried to keep it to an hour. But one of the things that I didn't mention is that we did receive as a state some HRSA funding 3 years ago, I think now, Helen. And part of that was to actually integrate oral health into those rural health clinics. And so actually adding, in one case, we added a public health dental hygiene practitioner. The rural health clinic sort of pushed all of their medical equipment to the side. This grant helps to pay for portable dental equipment. So with dentistry, one of the things to make a dental operatory, there's a lot of plumbing involved and some electrical work as well. The portable equipment takes that out of the equation. So maybe not ideal, but it helps to be able to set up a dental operatory. And so they set up this operatory, and they have started providing services of that public health dental hygiene practitioner. And actually, most recently, they've brought a dentist on site about 1 day a week to be able to utilize that portable equipment and offer services right in the rural health clinic. So if a patient comes in and sees the medical provider, they need some oral health care, maybe an extraction or filling, or they haven't had their teeth cleaned for years, it's able to be integrated. So hopefully we'll see that trend continue. We have this provider model now where it makes it really easy to integrate that public health dental hygiene practitioner. And again, sometimes cost comes into play, or space is the other issue with making sure we have space for that provider. But to be able to put that portable equipment in place and to have these models where we've successfully done it, I think will hopefully make more, be open to it moving forward.
Excellent. And the second question would be for Helen, and that's for regarding the free clinics. You had stated that there were 63 free clinics pre-COVID, and then almost half to 37, 8 are in the rural counties. So you also explained that there's a lot of people that were retiring, and the challenges to go back in, they decided not to reopen those clinics. Do you foresee them opening in the next year or two, or is it going to be something that's 5 to 10 years when a new group comes through to start opening these things?
I think it's going to be driven by need. And honestly, I think the need's going to be pretty severe. We're getting tons of feedback every week now from people really struggling to find dental care. So I think, we see these pop-up clinics like Mission of Mercy come up when there's a high need in an area. So I'd like to think that 5 to 10 years is a good goal to get some of these clinics back up and running. I'd like to think we won't need these clinics in 5 to 10 years. I'd like to hope that everyone could have a dental provider and not have to go to a free clinic. But with that being said, we're going to see a stronger need over the next year as sort of this whole workforce thing kind of goes through. So something's going to have to give. It may not be a brick and mortar building, but it's going to be something popping up.
Great, thank you.
Any other questions for Helen and Kelly? All right, I don't see any more popping up, so thank you so much. Really appreciate it. That was very informative. I hope everyone enjoyed our first session. We're going to take a quick 15-minute break where Helen will stick around. She's going to talk to us about the fluoridation project there, and we'll come back at 2:55 Eastern. So everyone stretch, get yourself something to drink, walk around, and we'll see everyone in 15 minutes. Thanks again.